Hi, everybody. Thanks for joining us. I have 12 o'clock Eastern now, so I'm just going to give it another minute or so for folks to log on, and then we'll get started with today's webinar. Thanks. Good afternoon, everybody. It's great to have you here today for our webinar. I'm Lindsay Browning. I am Program Director of Medicaid Programming at NAMD, and really delighted to welcome you to our launch webinar for our recent report, Medicaid Forward Long-Term Services and Supports. During our discussion today, I'm going to provide a little bit of an overview of who we are and why we undertook this Medicaid Forward initiative. Then we're going to hear some boots on the ground perspective about what's happening in long-term services and supports and why this work is important here and now. And then we'll dig into the report itself and hear some state examples of the opportunities and options described in the report. We have the option here for folks to ask questions throughout, so please use the Q&A function of the webinar feature here and drop your questions in. We'll either get to them throughout or at the end of the discussion. So with that, let's go ahead and dive in. So for those who don't know, the National Association of Medicaid Directors is a bipartisan nonprofit association that serves the Medicaid directors across the states and the territories. And our goal is to represent, elevate, and support the Medicaid directors so that they can deliver high-value services to the 80 million plus people who rely on Medicaid and CHIP. And really the end goal of that work is to allow and help folks to achieve their best health and thrive in their communities. So that's who we are. In addition to myself, I am joined today for our webinar by two phenomenal state Medicaid leaders. Ben Schaefer is the Medicaid Director in Rhode Island and a member of NAMD's Board of Directors. And Patty Killingsworth is the Assistant Commissioner and Chief of Long-Term Services and Supports at TennCare, which is Tennessee's Medicaid program. So what is Medicaid Forward and why did NAMD undertake this work? I think it became pretty obvious in the early days of the pandemic, and even more so now, that the COVID-19 pandemic and its economic impacts and the inequities that it brought to light really are having a devastating impact on the health and well-being of the nation and on the healthcare delivery system. We also know that Medicaid plays a key role in the health of Americans, with roughly 1 in 5 folks using Medicaid or CHIP to get the health care they need, and Medicaid and CHIP investing about $600 billion in the healthcare system each year. So Medicaid really is a critical core component of our healthcare system. In particular, we know that Medicaid and CHIP are and will continue to play a key role in the nation's recovery from the pandemic, particularly in a couple of areas where those pandemic-related impacts have been most significant. The first is around mental health and substance abuse. The second is access to care for kids. And the third, which is the focus of our conversation today, is on supports for individuals who need long-term care and long-term supports. So Medicaid Forward is an initiative, a 3-part initiative that delivers a strategic framework of options for states that's shaped by Medicaid leaders and national experts, really with the intention of helping Medicaid programs do this work of contributing to the nation's recovery. Medicaid Forward Long-Term Services and Supports is the third in this 3-part series, and we're really excited to bring you this work today and to share what's been done through that. Our executive working group who shaped the report are listed here, and I just want to take a moment to thank them all. They spent many, many hours on Zoom with us, thinking through this work and the opportunities that states have. And I'm delighted that the two of them are joining me here today to provide some real world on the ground insights for you all. So before I jump into the report itself, I wanted to take a moment to turn to Ben and then Patty, just to share some reflections from the front lines. They've been on the ground leading this work in their respective states, and wanted to start it off by hearing from them. So Ben, I would love to turn to you first for a couple of opening reflections, particularly from the Medicaid director viewpoint. Sort of, what are your reflections on kind of why you're spending your time and energy thinking about LTSS right now?
Sure. Thank you, Lindsay, and thank you, NAMD and everyone who worked on this Medicaid Forward report. It really was a privilege to be a part of the process and to share it with you all today. We outside certainly of the public health emergency, which I think has obviously shown a pretty bright and not always positive light on long-term service and support generally, our long-term care system, and Medicaid's role in it. This has always been an area of focus of mine and of our organization over the last certainly couple of years. And I think that really boils down into two elements. Anybody who's working for a Medicaid organization, Medicaid director, has to decide where you're going to spend your time and energy. And in Rhode Island, as in many other states, LTSS is a place where the financial impact and the quality impact and the human impact really converge and are quite simply too great to ignore. We wish we would have done more of this work, before the public health emergency, as many I think wish that they did. But the next best time to start is obviously now. Everybody knows, you just covered some of them, the significant expenses from a state and federal side that come in the area of LTSS. But we also know, certainly in Rhode Island, and I think some of our providers, members, and advocates may be on today, stress that despite all the spending, more spending is needed in smarter ways to improve the system. And on a personal note, that's quite the puzzle, and that's a puzzle that we're facing in Rhode Island. It's a puzzle we're facing in the country, and it's something that I think we all are trying to figure out together. That's quite frankly, it's a privilege to be a part of. Beyond the sort of financial implications, I know what attracts many to this work, including myself, is the personal and human nature of it. Everyone has an older parent or grandparent, aunt, uncle, friend, whoever, that is trying to navigate this incredibly complex system. And many do it with knowledge of the system, its options. They have resources to rely on. So we try and remember, as we're constructing policy alternatives, as we're looking at where to spend our time, that the people we're trying to help, our Medicaid members, likely have very little of that institutional support or that knowledge. They probably have negative experiences with the healthcare system. And if we're being really honest with ourselves, they probably have had negative experiences interacting with state government and with Medicaid agencies. So we want to recognize that. We want to understand and know that this is a population that's been disproportionately impacted by COVID-19, and something not only that we can't ignore, but that we owe it to them to make significant progress on.
Thanks, Ben. And Patty, I know you've been deeply engaged in transforming and strengthening long-term care for some time. I would love to ask you just to reflect a little bit on kind of the uniqueness of the moment and time we're in, and sort of why you see an opportunity now.
Sure, Lindsay, I'm happy to do that. I do want to echo Ben's remarks. I'm incredibly grateful to NAMD and to everyone who participated in this really important conversation. We certainly hope that this information is helpful, that people will take it both to heart and hopefully to hand, and really applying it to help move home and community-based services forward across the country, because the time that we're in is very unique. I've been in Medicaid and in LTSS now for more than 2 decades, and I've never experienced a time that is more challenging than the past 18 months or so have been. This has unquestionably posed the greatest threat to the health and safety of the people that we serve, that I have certainly ever observed. Nearly 21,000 residents of Tennessee's nursing homes and assisted living facilities have been infected with COVID-19, and almost 2,800 of those people have died. That's 18% of the total deaths that we have seen in our state. If we look across the country, the numbers are just staggering in terms of the impact as it relates to people who receive long-term services and supports. More than 700,000 nursing home residents who've had confirmed cases, more than 137,000 deaths in nursing homes across the country. 1 in 10, almost 1 in 10 people who receive nursing facility services have passed away as a result of the COVID virus. And we thought things were getting better, right? We saw the trends getting better, and then the Delta variant came along and things quickly began to reverse. And so we're back to 1,700 deaths just in August, a couple of months ago. And while that's a far cry from the 22,000 a month that we were seeing in December and in January, it's still too many people, and it still signals the need to really do something to try to find better ways to provide services and supports to people. Even for those who survived, there have been just incredible disruptions from COVID. And in particular, just the overwhelming social isolation as nursing homes locked down all across the country and really stayed that way for months and months on end. And certainly home and community-based services were not immune to these challenges. We saw significant impact there as well, not as great, but nonetheless really impactful for the people who receive services and the staff who support them. Across the country, severe workforce shortages reached really crisis level proportions as frontline staff became ill, as they were exposed, as they needed to remain home to care for sick loved ones or school-aged children, and just a shrinking workforce became even smaller. And so as Medicaid agencies, I think we really struggled to adapt how we do what we do. We struggled to ensure continuity of these really important benefits for people who receive them. And we sought to try to understand what we were all still learning about on the fly, and then provide guidance that would both to help to keep people safe, but also well, because safe isn't enough. Even as we watched our state budgets really begin to dwindle away from all of the economic impacts of the pandemic. In Tennessee, and I assume probably across the country, much of that really promising work that we had been doing on transformation was kind of put on hold for a bit as we were really focused on this, and due to a lack of resources, both financial as well as staffing. And so there have been some really dark days over the last 18 months. But I will say that it is in the dark that the light really shines the brightest. And so also in my more than 2 decades of Medicaid long-term services and supports, I've just never seen more incredible opportunities than the ones that we have before us right now, especially as we think about the funding that is available to us. I don't know how often we really get to step back and really think about how to envision a better future, how to re-engineer our systems with momentum, and importantly with resources that can really help us fundamentally transform our long-term services and support systems. We can't do everything, but we can do some things. And so one of the things I love about this report is it really prioritizes opportunities that we think states can really seize and take advantage of to move forward in transforming their systems, leveraging these dollars potentially for future funding, both at a state and federal level. One more thing I'll add is that in addition to great challenge and great opportunity, there has never been a greater need for leadership. And that's why I appreciate Ben, I appreciate the Medicaid directors across the country, the people who lead long-term services and supports across the country, for bringing innovation, for bringing vision and commitment and courage, to really step up and do not what's easy, right, but what is right, what's really needed to take advantage of these dollars, because the crisis, we hope, will eventually end and the doors of opportunity may at that point close. But now it's before us and we have funding and we have time on our side. We maybe have opportunities to influence at a federal level some of the longstanding institutional biases in the Medicaid law and in the regulation, even while we begin, each of us in our own states, to really leverage this report, this funding to really move our systems forward.
Thank you, Patty. That was beautifully said in an inspiring call to action and the work ahead of us. I want to kind of lift us up and reiterate a couple of the things that they said that kind of are the confluence of realities that led to this report, that led to the options that are described in it. And Patty and Ben both hit on the first one, which is really just the severe impact of COVID on individuals receiving long-term care, and the fact that nearly 1 in 10 individuals in nursing homes have died of COVID during the pandemic, and just kind of putting a light on the opportunities to strengthen the long-term care system, to support choice for individuals in the long-term care system, and put the person at the center. The other reality is that these challenges in the long-term care are happening at a time when the need for services is growing at a pretty significant rate. We know that the number of older adults over 65 is going to double in the next 4 decades. And at the same time, technological and healthcare advancements are allowing individuals with complex needs to live longer. And then the other piece of this increasing demand is, that we're still understanding the long-term impacts of COVID and long-haul COVID, and whether more individuals may look to Medicaid for long-term services and supports as a result of that. The other reality is that the equity impacts of the pandemic that I mentioned earlier, but we've started to see studies that show individuals living in nursing facilities in communities of color were infected with COVID and died at disproportionately higher rates than their white counterparts, really showing us the importance of bringing the equity work that's happening in the healthcare system to LTSS and bringing that equity lens to it as well. And then, as Patty mentioned, and I think Ben mentioned as well, there's this increased funding from Congress. It's time limited, but the opportunity to have some of the seed funding to do this transformational work is sort of converging together with these challenges to create an opportunity to use the disruption and drive some lasting and meaningful transformation. So it was out of that confluence of realities that the Medicaid Forward LTSS report came together, and recognizing that Medicaid is a core component of the nation's long-term care system, providing about over half of the nation's LTSS spending and serving millions of kids with complex needs, older adults, individuals with intellectual, developmental, and physical disabilities. So really a broad and heterogeneous population. And that Medicaid programs have an opportunity to double down on the transformation that was happening pre-COVID, to rebalance care from nursing facilities and into the community, and to provide choice for people of where they wanted to receive care and live and thrive. And that this is an opportunity to accelerate the pace of that work that was already happening. So the Medicaid Forward LTSS report elevates opportunities for states in 4 areas. And these 4 areas are the ones that the executive working group felt were the most immediate places for action. And I'll get into each of those in a second. But I also wanted to point out something unique about this particular Medicaid Forward report, which is that it also looks at ways that the federal government, particularly CMS, really needs to come alongside states for this work to succeed over the long term, and including in the partnership happening around some of this new investments, this one-time investment in HCBS. I'm not going to spend as much time today on that last piece, but I do encourage you all to take a look at some of those federal opportunities for partnership in the report as well. So the 4 opportunities for action that we look at in this Medicaid Forward framework are to build and strengthen the long-term services and supports workforce, to assist and strengthen individuals' natural supports, so friends and family who serve as caregivers, to promote the adoption of telehealth and assistive technologies that can really drive and support the goals of independence, health, and safety. And then finally, the 4th area opportunity is to advance person-centered outcomes and quality through innovative payment approaches. So I'll go into each of these in turn and lay out a little bit about the options, the menu of things that may be possible for action there. And then I'm going to turn it to Ben and Patty to provide some examples from each of their state across these 4 areas. And I'm sure folks will have questions and discussion on those. So again, feel free to use the chat and drop in your Q&A. Okay, so the first area that we looked at that the group really prioritized is building and strengthening the LTSS workforce. And this probably is not a surprise to anybody on the webinar today, because we know that the workforce, the LTSS workforce, has long struggled with shortages and high turnover. But the pandemic really exacerbated and decimated the workforce even further. So the group identified options and opportunities to strengthen the workforce, both to meet current need and also that future need that I mentioned of an aging population and more folks who are looking to Medicaid for LTSS. So some of the options and opportunities we explored as a group are ways to finance and incent the professional development and a career ladder for service providers. And this work, often has to be done in partnership with universities, community colleges, and others in the state. But that Medicaid can use some of the financial incentives that it has as a payer and quality improvement requirements to promote and drive some of that professional development for folks. The other opportunity we talked about is to evaluate and to promote a culturally reflective workforce. And this speaks back to the equity concerns that I raised a little bit ago of it's not just about expanding the workforce and creating stability. It's about making sure that workforce is reflective of the individuals being served. We also, an option described in the report is to look at policies and standards that ensure workers are practicing at the top of their license. Now, Medicaid isn't responsible for scope of practice, but Medicaid does have an opportunity to provide an educational role or a clarifying role to providers about what's allowable or what's not under scope of practice, and also to play an educational role with sister state agency partners who may be responsible for scope of practice and help them understand how the current policies may impact allowing folks to live in the community safely. The other opportunity we looked at is, some ways to increase compensation and benefits, as well as non-monetary supports that can make this profession more attractive to folks and keep folks in the LTSS workforce. And there are even some value-based ways to do that, right? To align some of the compensation with the tasks being provided or the outcomes that a worker may be helping an individual to achieve. So there's a range of strategies there that go beyond just increasing pay. And then finally, we lay out some thoughts around self-direction, that this has become an increasingly popular model for folks to allow an individual to manage the services they receive, including who provides those services. And this can also speak to that earlier point of making sure that the workers are culturally reflective. The second opportunity that we looked at is some of the ways that states can assist and strengthen individuals' natural supports. So natural supports are the friends, the family members, faith community, others in a person's life who provide support, who help them live and thrive. And Medicaid historically hasn't played as significant a role in supporting these natural supports. But I think there's a growing recognition that if we're going to meet the need, the demand, and we're going to, again, provide a person-centered system, that there are opportunities for Medicaid to do more in this space. Some of the strategies we looked at are how do we, have more authentic inclusion of all of these individuals in the person-centered planning process, so that their voice is heard and their input is part of that. Again, increasing the use of self-directed models in LTSS is another opportunity. And then providing some supports for the natural supports. And we're seeing some of this in the American Rescue Plan Act, the HCBS spending plans of, maybe providing some pay for the family caregivers, providing behavioral health services and supports to them to help support their resilience. And in all of this, I should have said this at the outset, the goal and the main pivotal challenge for Medicaid in strengthening natural supports is how do you support their resilience and enable them to continue to provide those supports without supplanting them. And I think that's the crux of some of these policy questions in here. And just to hit on these last two, there's an opportunity that some states have pursued to empower case managers to ensure they're assessing, or to use them to assess the needs of the family caregivers and to play more of that role in the care planning process. And then finally, for those who use managed long-term services and supports, opportunities to incentivize the managed care plans to use their flexibility to support the natural supports, whether, again, it's paying for family caregivers, providing respite, providing behavioral health supports, et cetera. And one example of that is Florida's MCOs provide behavioral health supports for family caregivers as a value add service. So again, kind of demonstrating that flexibility that MCOs have. The third area that we looked at is how Medicaid could promote the adoption and use of telehealth and other assistive technology with the goal of supporting independence, health, and safety. I think this is one of those silver linings of the pandemic, where we've seen individuals, providers, consumers across the board kind of embrace technology in their lives in ways that we hadn't seen before. And I think we see an opportunity for using that moment, using that silver lining to double down on the use of technology in long-term services and supports, both for those clinical services, clinical care delivery, and for other supports that can allow them to have independence and live and thrive in the setting that they choose. And some of the ways that Medicaid can do this is, removing barriers to the use of technology in policy, ensuring that, plans and providers have clarity about the policies around technology, and also using payment as a way to incentivize the use of technology as well. And I listed on here a couple of areas where, the executive working group sees real opportunity for technology to drive some of the goals that we want to see or that we want to support. But I will say that, when it comes to assistive technology, we're still kind of getting our hands around the definition of what it is. And I think there's real opportunity here for the community, the LTSS community collectively to continue thinking and working in this space. Finally, the fourth area, the fourth opportunity that we look at in this report is advancing person-centered outcomes and quality through innovative payment approaches. And I know this is a mouthful, but I think it's really important to break down exactly what this means. Payment, as you all know, is one of the main levers that we have in Medicaid to incent and transform care delivery. And that includes in long-term services and supports, where we're seeking to transform the system to one that is more person-centered. We've been challenged in Medicaid to do this, though, because of the lack of person-centered outcome measures. We have some measures of patient safety and measures of program compliance in LTSS, and the national core indicators, which look at a person's experience in key areas. But what we're really lacking is measures of person-specific and quality outcomes. And that's making it challenging to use payment to drive changes in care delivery that are person-centered. But at the same time, the group in this report looks at what are some of the ways that Medicaid can move forward, even in the absence of those more robust measures, to drive person-centered care. And the four that we look at in the report are listed here. The first one is around right-sizing institutional care. And I want to acknowledge, because I don't think this has been said yet, that there is and always will be a role for institutional care in the LTSS continuum. But we're increasingly seeing evidence that kind of smaller, more innovative models can deliver better outcomes for folks, like the greenhouse model, and that Medicaid can use its levers as a payer to incentivize those smaller, innovative institutional settings. The second opportunity is using payment as a way to ensure that the workforce is sufficient and well-trained. And this goes back to what I was talking about a little earlier, where you can link those payment incentives to certain training requirements or expectations around training, and provide some financial incentives there that does it in a value-based way. Also, an opportunity around value-based payment for institutional care. Institutional care, we have a little bit more on the quality measure side. We have the minimum data set that can be tied to payment. And we've seen some states do this as a way to move institutional care towards a more value-based approach. And then finally, leveraging or advancing a portfolio of value-based payment arrangements in home and community-based services. In home and community-based services, we know these are smaller providers, they're less able to take on risk. And this is really where we've struggled with the quality measure piece that I talked about earlier. But payment can help start to build towards transformation. And this concept of a portfolio of value-based payment arrangements can help unique types of HCBS providers move in that direction. So some of the examples we looked at are, maybe an add-on or a kicker payment for serving more complex patients, pay for performance around a variety of activities that we know can move us closer to person-centered care, like using electronic visit verification for timeliness of visits, or a fading model where service providers are incentivized to get the results we want to see, like employment supports for individuals with developmental disabilities, right? Making sure that there's no financial disincentive for achieving that goal of employment. So a variety of steps that can be taken even in the absence of the ideal, patient-reported outcome measures that would help us move even further down the road. So let me stop there, and I would love to turn it to Ben and Patty, because they've been living and breathing this stuff on the daily and making these policy choices and options in their program. So would love to hear from the two of you about some of the ways that you've advanced those four areas of workforce, natural supports, technology, and around payment. So Ben, let me turn it to you first, and then we'll go to Patty.
Sure. Thank you very much. And thanks for walking through sort of all that. It's an incredibly comprehensive report, and even just listening to you kind of go through it again, I was remembering things that we were talking about in the sessions, which was really great to hear. I want to just do two quick caveats before I jump into specific examples. One, I think there's a good argument to be made sort of across all of what I'm going to talk about, particularly around building and strengthening the workforce. That this is an area that just simply will require better support for workers overall and better pay, and that oftentimes means better rates. We know we certainly hear that in Rhode Island. I'm sure many other states are struggling with that kind of work as well. But we do want to highlight, or I want to highlight, some of the innovative things that we're also doing that really need to be built on top of that foundation, that this work is valuable, that the people who do it are likely underpaid, and something that we need to correct. And then lastly, as a caveat, I'm going to offer some things that we've done or are in the progress of implementing, but also kind of throw out some things that we're working on that we certainly haven't figured out yet. Oftentimes it can feel like sort of the panelists have it all figured out, And I just want to dispel that notion right off the top. This is certainly a lot of work in progress and things that we're testing and trying and want to keep going on. So with those introductory caveats out of the way, for us it starts with where the report starts on building and strengthening the workforce. If you don't have workers, you don't have access. If you don't have access, you don't have care, and nothing else, quite frankly, really matters. We are, in addition to some of the other rate actions and support that we've talked about, we proposed and our General Assembly approved, and we're in the process of implementing a workforce pay enhancement built around behavioral health certification. And this is an enhancement, a specific enhancement to any worker who completes a behavioral health certification program at one of our community colleges here in Rhode Island. But the trick here in the program design, and it sort of bleeds a little bit into the value-based payment conversation, was to make sure it's enticing both to workers and employers. So we're trying the following. So home health agencies that have 30% of their workforce complete the certification get a little bit more than $1.50 an hour increase in billing rates. Workers who have completed that training must be paid that increase as a pass-through, but workers who haven't completed the training, don't have that behavioral health certification, are not required to get that wage pass-through, and the home health agency can allocate the funding as they see fit. We, again, trying to figure out a way in which we want to incentivize home health agencies to provide or allow for the training, make it worthwhile to the workers, and again, build up the competency of the workforce. We piloted this in the middle of the pandemic with home health agencies using other federal funding, and it went well. So, and I know actually some of the people who worked on this, whose idea this was, are on the webinar today. So I want to publicly thank them and everybody else in Rhode Island who worked on a lot of these innovative ideas. Additionally, in this sort of workforce item, I just want to touch briefly on the self-directed point. That means a lot of different things. It's a challenging area, but I will share that the thing that we're really focused on trying to understand how to do in Rhode Island is build out a registry and understand how we can create that marketplace, how we can improve the use of that registry, again, for individuals who aren't necessarily used to engaging with government in that way. That's not just a technology problem or a process problem, it's a trust problem. And something that we're really looking at different ways of doing, something that quite frankly has been very challenging for us. I want to jump sort of all the way to the innovative payment approaches, because while, as Lindsay said, it is weedsy, we are Medicaid, we are a payer, and to us, that's kind of where we should start. We sort of are trying our best to sort of focus on this one, more on the nursing facility side. We believe that there absolutely is a role for nursing facilities in this work, but that we want to look at ways in which that can really be used to expand the continuum of care. So with CARES Act funding, which is one of the major pandemic pieces of legislation, we in Rhode Island launched a $10 million investment in nursing facilities who wanted to take existing capacity and turn it into something else. Could be an assisted living, could be single occupancy room, could be specialized behavioral health capacity. And we in the middle of the pandemic, which is crazier every time I think about it, we ran a little mini RFP process and are supporting 10 skilled nursing facilities to take 123 beds out of service and devote 211 beds to support with specialized needs, particularly around the area of behavioral health. In addition to the sort of impact on the bed side, a very positive byproduct of that from our perspective has been launching a learning collaborative to hear directly from nursing facilities who wanted to continue to work on those ideas. It's also been a way, quite frankly, where we get to hear some of the hard truths and hard realities that they bring forward about what it takes to engage in this kind of transformation work. And from that, we get other policy ideas, which is the last example that I'll share, which is something we're currently proposing or potentially proposing. But one of the things we heard from a lot of the nursing facilities interested in that kind of transformation was, hey, if you want us to move to single occupancy rooms or something like the greenhouse model with Lindsay, which Lindsay, you mentioned, your payment model doesn't support it. We need a different kind of room rate. Your room rate for nursing facilities is currently based on a 2-bed model. And you can talk all you want about how important single occupancy rooms could be, particularly following the pandemic, but you got to make the financing work for us. So for consideration in our next year's budget, we've put forward an idea to simply create a new single occupancy room rate. I'll grant you, this is not the most exciting thing in the world. This is not a fancy value-based payment, downside risk, et cetera. But understanding how fair rental value changes need to be incorporated into such a rate is really important for the nursing facilities to try and make it work. And it's that kind of, in the weeds, nitty gritty work that, at least in my opinion, ultimately will be the difference between success or failure of some of these innovative payment approaches. So thanks for letting me share that. And I think I'll turn it over to Patty.
Awesome. I always love to hear what other states are doing. I feel like we learn so much from each other. I'm going to focus mostly on things that are in our initial spending plan for the HCBS FMAP. I may throw in a few things that we've already done. But we've sort of aligned our plan around 3 primary areas of focus. And it's nice to see that those 3 areas of focus really align pretty well with the 4 areas of opportunity that are outlined in this plan. The first is really focused on the people that we support and trying to increase access to home and community-based services for people who need them. And we'll start out with a significant waiting list reduction item. We plan to serve 2,000 people who have intellectual and developmental disabilities and who are waiting to receive home and community-based services. That's over half of our total waiting list. It's the only waiting list that we have. So it's a significant opportunity for us to really have an impact in that population. It is an area where we recognize that recurring dollars will be needed once these funds expire, but it's important enough to not miss this opportunity. We're also across our entire Medicaid HCBS delivery system going to provide time-limited additional access to services that are really important to family caregivers. So things like respite and home modifications, technologies, those sorts of things that help to increase independence, reduce caregiver burden, reduce burnout. We really want to make sure that people have access to those, even if they've exhausted benefit limits or expenditure caps. So it's a one-time $3,000. Every person who has unpaid family caregivers can access those additional benefits. And then a significant focus on making sure that every population has access to enabling technologies that can increase their safety and independence in the home. That is going to be a really important area of focus for us going forward. Second thing, not because it's the second most important, it really is essential, as Ben talked about, is around that workforce. We're going to spend about $137 million in raising the frontline workforce wages through provider rate increases that are required to be passed through to that frontline workforce. We've been able to increase rates in certain parts of the program, but not others. So this is an opportunity for us to really align like payment for like services across programs and populations. But we also have other workforce investment opportunities. One of those is very much like Ben talked about with respect to their behavioral health certification, but it's a broader workforce certification for all frontline HCBS workers. We actually had funding to launch this pre-COVID and it was lost as a result of COVID. So it's a chance for us to get started again. By offering this, it's a post-secondary certificate program tied to direct wage increases for the frontline workforce who actually completes that training program. And so that incentive pay is a part of this. It is also kind of leads us into a third area of focus, which is really around provider capacity broadly. So yes, we have to increase workforce capacity. We also really have to strengthen our provider capacity, make sure that providers are not just sufficient in number, but importantly, sufficient in quality to really deliver the outcomes that we're looking for. And that's where that value-based payment really does come into play. We started back in 2013 on a nursing home value-based payment strategy. We now, every payment that we make to a nursing home has a value-based component that's aligned around person-centered outcomes. So we're really happy with that, but it's much harder to do in home and community-based services. As Lindsay talked about, it really is identifying different kinds of opportunities that can begin to embed value-based payment within the home and community-based services delivery system. We've been really successful in doing that in employment services. One of the things that Lindsay talked about in specifically is fading. And our job coaching payment strategy rewards providers for fading in job coaching. So we'll pay you more per hour if you are successful in helping the person you support be less reliant on those paid supports. One of our health plans now has over half of the people that they support in employment completely independent, needing no paid job supports. And that was unheard of before we established a value-based payment approach for job coaching. So great opportunities there, but we're really focused on trying to help build provider capacity for the next iteration of value-based payment, which will begin to make it much more broadly embedded within our delivery system across residential services, across personal care type services, really those frontline services by beginning to introduce, first of all, incentives for building capacity to deliver the outcomes that we really want to see, and then ultimately being able to pivot those payments to the real outcomes once we're confident that one, providers have the capacity to deliver them, and two, we can figure out how to measure all of them so that we can fairly apply that payment methodology.
That's great. Clearly lots of work going on in both your states, and appreciate you sharing that. We're going to turn to your all's questions now, and I see we already have one come in through the chat. Ben, I think this is for you guys around the conversion of some of those nursing home beds to focus more on behavioral health. How are you all dealing with the IMD exclusion in that? And then how does it comport with any Olmstead concerns as well?
Yeah, it's a great question. On the IMD side, I mean, individual facilities are looking at their overall composition to make sure they're not kind of running afoul of the IMD exclusion. And for those that are proposing more focused behavioral health specialized beds, it's a smaller percentage of the overall bed count in the facility. So I think they're reasonably comfortable with where they are from an IMD perspective. For Olmstead, we're really trying to make sure that this isn't for lack of a better term, a warehousing sort of model. But like many states, we're dealing with a lack of continuum of care in behavioral health as well. And part of what we're trying to do with in particular, one of the nursing facilities that's working on this behavioral health beds with us is understand what the care model really needs to be, not just the payment model or not just the beds, and that's really not to have them go from a hospital emergency room to a nursing facility and have it stop, but have them integrated back into the community as well. So the nursing facility in particular, in their application, talked about the care models that they were going to bring in, the behavioral health provider partners that they would work with, and the like. So that is one I will share that has been, that's a lot harder than just, signing a form that says you're taking beds offline. We're continuing, to work on rates. We're continuing to work on those care models to get at a lot of in particular, the Olmstead concerns that the questioner raised.
Great. Our next question came in is for Patty. So Patty, how much and how is the VBP, the value-based purchasing arrangement with nursing facilities structured? In particular, is it like a percentage or a flat fee, and what are the value-based criteria?
Yeah, that's a great and complicated question. So really quickly, first of all, we have a quality incentive pool. When we started the quality incentive pool, it was set at 4% or $50 million, if I remember correctly, of the total nursing facility expenditure. But when we rebase rates, anytime we raise the nursing facility rates, we have to raise the quality component in the rates by at least twice as much as we raise any other component in the rates, so that we can ensure that continues to build until it gets to 10%. So that's the ultimate goal for the quality incentive pool, that ultimately then gets divided and apportioned out as a part of the per diem payment. In addition to the quality incentive pool, there's an acuity adjustment that's based on uses the MDS and based on the case mix. And then finally, there are quality levers that are built into all of the other rate components. One of the things that Ben talked about is the importance of paying for private pay. So we incentivize through the way we do our fair rental value assessment facilities to establish private rooms for people. That's a part of the payment methodology. There are other areas where the percentage or amount that a nursing home is paid depends in part on those quality scores. And the quality framework was really established in partnership with stakeholders to focus primarily on aspects of person-centered care. So satisfaction is a component of that. Choice and dignity is a significant component of that. There are 4 measures around that. Workforce is a really important component of that. So we look at the consistency and quality of the workforce for people. And then there's a couple of clinical measures that we look at. One of them related to the use of psychotropic medications and the other one related to infection, but those are a relatively small part. And then there's a bonus points, if you will, that are really related to quality credentials that we believe really position nursing facilities to deliver higher quality care.
Great. Another question for you, Patty. You mentioned when you're talking about your HCBS funding that you're requiring a certain percent of that rate increase to be, or you're requiring it to be passed on to frontline workers. Are you requiring a certain percentage to be passed on? And generally, what kind of feedback have you received regarding that pass-through requirement?
Yeah, it's a great question. We essentially applied a value of 1.2. We allow the 0.2 is what the provider gets to keep. So for every dollar of wage increase that's funded, the provider gets to keep a 20 cents on top of that, if you will. It's not 20 cents of the dollar. But that's the way the math kind of works. So for every dollar that passes through, the provider keeps 20 cents on top of that to cover cost of payroll taxes and other expenses associated with maintaining or paying a higher wage to staff. It's almost entirely passed through. There was a basis to do that, both on in terms of how our General Assembly has previously funded wage increases in our 1915C waivers. But there's also just overwhelming support and belief that the greatest need right now as it relates to provider rates really are around the workforce. And so we want to make sure that those dollars are actually getting passed through. We're not going to mandate a specific dollar amount that a worker has to be paid. We really do want to allow providers some flexibility there, but they do have to be able to demonstrate how they are passing through the entirety of the amount that they're supposed to pass through into wage increases.
Lindsay, I know the question went to Patty, but for the Rhode Island sort of perspective, I would just validate that sort of 80 to 85% for us, sort of pass through the 20 to 15%, for employer costs on payroll is also what we're looking at, both for things that have passed our General Assembly and then in addition to other HCBS items. The other thing that we're just looking at, since the questioner also asked about sort of reaction to that, we haven't done, I think, necessarily the job we'd like to do on kind of standardizing what those are, right? So General Assembly passes, wage pass-through requirements for nursing facilities might be different for what we proposed for a different provider. And I think reasonably our provider community is a little bit confused by that, and it's something that we want to take a look at. So as we look across the whole continuum of care, and certainly agreeing with Patty that what we hear about the biggest concern is support for the workers being able to attract and retain talent. The wage pass-throughs are something that we're quite firm on and think are incredibly important. But getting that percentage number right and consistent is certainly something we continue to work on.
Yeah, and one follow-up question from David on that is whether this would be applied to direct care providers with an HCBS or all providers, kind of your typical and atypical. Any thoughts from either of you guys on that?
Yeah, we're only increasing wages for services that have a frontline workforce component. This is really targeted to that frontline direct support professional.
Got it.
For Rhode Island's, version of what we're working on in home and community-based service, FMAP, we're targeting frontline workers, but for other types of workers, particularly in behavioral health, case management kind of workers, peer recovery and the like, we're looking kind of more expansively at that, as well as some of the staffing ratios that you might have to have for a nurse versus a specific direct care worker, where a nurse might be in a supervisory role. We don't want to draw the line too restrictively, so we can make sure we're not sort of running into afoul of any of those requirements. So just put a slight sort of maybe spin on that frontline worker focus.
Got it. Another question came in that I think speaks to some of the challenges we've been seeing on the workforce front. And it's around some of the support for respite care, and how that maybe works in your all states, how folks can get respite, particularly when there may be staffing shortages and folks may not be getting the hours they need. So I don't know, any reflections broadly on respite and those workforce concerns and how they may play together?
So I'll jump in real quick, Lindsay. For us, when I talked about the one-time increase in the availability of benefits that will support family caregivers, respite is among those benefits that we are prioritizing. So one, making sure the benefit is available if somebody's exhausted all of the hours or days that they can already have. The second workforce issue is obviously a more challenging one, and so there we are hoping that the targeted rate increases that we're doing that will help providers pay the frontline workforce more will really help to ensure adequate staffing. We do have self-direction or consumer direction models available broadly throughout our programs. Respite is an area where oftentimes people prefer to identify someone they know to be able to deliver those services, and we have the availability of options for them to do that.
Great. A couple more questions in the chat. So one that I think I could actually answer, which is, and I'll take a first crack at this. How are states addressing the need for internet services in order to support access to telehealth and other IT supports or AT supports? Part of the report, when we talk about the federal barriers, we actually call out the importance for flexibility for states to be able to support that connectivity for individuals receiving LTSS in order to address those challenges. I think there's a clear recognition that, if we're going to leverage technology effectively, that we have to think about, the connectivity problems as well. But Patty, Ben, anything you want to add on that question?
There have been some additional funding sources been made available to states to really help them with broadband issues. And of course, the state fiscal recovery funds, that is one of the focus areas in terms of infrastructure for states there as well. So I think our state will probably leverage some of those dollars to invest in that area.
I think Patty's exactly right. I think this is a place where Health and Human Services leaders, more broadly, should continue to make the case about why broadband is important and be, advocates for their members and their communities. Connecting broadband in an urban area, depending on housing situation, is different than sort of rural broadband. How do we make sure that the needs of our members are met as there's continued attention on access to broadband overall and the appropriate federal and state funding for it?
And last question here, because I know we only have a minute or so left. Are you guys contemplating any incentives around reducing disparities for individuals receiving LTSS, kind of either geographical or race and ethnicity based? And then what about any incentives to reduce disparities around staff recruitment and advancement?
I can start.
Okay.
We are. I don't think we've cracked the sort of incentive sort of nut yet by any stretch of the imagination. But we certainly, as we think more about the sort of the geographical and race ethnicity based disparities, this is a place where we have a lot of hope for our self-directed programs and self-directed growth, particularly to allow clients to find those caregivers that they feel comfortable with, that are culturally appropriate, that are in their geography, they're not sort of traveling sort of large distances. And while Rhode Island is a small state, we still have geographic disparities in access, particularly on some of the peninsulas and islands that we have here. That's really a place where if we have a bigger, a more built up self-directed sort of population of personal care attendants or other kinds of workers who can support that area, we think it would be a lot easier and reflect the geographies, the communities that our clients are coming from. So to us, I think my answer to that question is continuing to invest in self-direction amidst all the other things that we're doing, and we hear that from our communities as well. They're very interested and open to that approach.
And I would add to that only, I agree with everything Ben said. I think there's an important focus around how we provide care management as well, and trying to make sure that we are culturally competent in that area. And that's certainly an area of focus for us with our health plans.
Wonderful. And on that note, I want to take a moment to thank you guys, Patty, Ben, for sharing with us today, and everybody for joining us. This isn't the end of our work in this space. We're going to continue to offer programming to Medicaid leaders around some of the options described in the report. And we're also going to have a big focus on long-term services and supports at our fall conference. So if you haven't registered, sign up, and we hope to see many of you there. And then, of course, stay connected with us at NAMD. You can sign up for our state-only newsletter or for our partners newsletter on our website. So thank you guys so much. We hope this was useful, and please feel free to reach out to us at any time. Take care.
Thank you.